It's a pleasure to be speaking to you today at this European edition of Management of the Complex HIV Patient. And I'm going to talk about how to identify the complex HIV patient and approach their treatment. These are my disclosures. Patients with complex HIV infection come in many different varieties. There may be those who have difficulty adhering to treatment, those who are unable to tolerate multiple different antiretroviral drugs, making a choice of regimen hard. Many people with comorbid conditions or medications that preclude use of certain antiretroviral drugs due to drug-drug interactions. People with a repeated history of treatment failure, and of course, the presence of multi-class antiretroviral drug resistance. Now, it's important in considering the complex patient, how do we define virologic response and virologic failure? Virologic suppression is relatively straightforward. It's a confirmed RNA level below the assay limit of detection. Virologic failure can be more nuanced. In its simplest form, it's the inability to achieve or maintain suppression of viral replication to a virus level below 200 copies per mil. But you can have an incomplete virologic response where two plasma HIV RNA levels after 24 weeks of starting treatment are still above 200 copies in a patient who has not yet achieved viral suppression. One can also have virologic rebound, a patient who initially became fully suppressed and now is having return of viremia. And making this somewhat more complicated is the occurrence of viral blips, where after viral suppression, you can have isolated detectable episodes of viremia, which then resuppress on rechecking the virus load. Those do not constitute virologic failure. Well, what are the factors that contribute to incomplete suppression of virus replication? First and foremost is poor adherence or challenges with adherence to an antiretroviral regimen. There may be pharmacologic factors, either drugs or foods that interfere with the absorption of antiretrovirals or that accelerate their clearance. There can be socioeconomic factors that make it challenging for patients to be able to access their therapy, to renew their prescriptions in a timely manner, and to be able to keep a supply of medication at home to be able to take their drugs on a regular basis. And less common today, but a big problem in previous years was the potency of some regimens was really inadequate to achieve full suppression. And in some parts of the world and in the past here in the West, transmitted antiretroviral drug resistance was a reason that certain regimens might have been less effective than expected. Let's talk for a minute about the problem of drug resistance. The emergence of drug resistance is a particular problem with many RNA viruses, not just HIV, but it's a particular issue with retroviruses. These virus populations comprise a quasi-species where there are many very closely related viruses circulating simultaneously in an individual, all recognizable as that person's strain, but each slightly different from the other. And that's because a genetically distinct variants or group of variants evolve from an initial oligoclonal inoculum. These variants are generated by the error-prone RNA-dependent DNA polymerase, or the reverse transcriptase in the case of HIV. If we think about this quantitatively for a moment, the HIV genome contains about 10,000 nucleotides, and it has a mutation rate that is roughly 1 in 10,000 after you round up. Now, since there are about 10 billion virus particles generated every day from somewhere between 10 and 100 million rounds of replication every day in the untreated patient, you can see how every single possible mutation can be made many times a day in somebody who has chronic HIV infection, not controlled on antiretroviral therapy. And that allows, of course, for the emergence of drug resistance mutations that can then be selected by therapy when therapy is started. So in the bad old days, going back 15 years or more now in Europe and in the United States, in the era of mono and dual therapy, failure to achieve full suppression of HIV replication invariably led to the accumulation of multiple drug resistance mutations. The accumulation of these resistance mutations then led to increasing within-class cross-resistance. So More and more mutations for AZT resistance led to higher resistance to didanosine, to stavudine, to abacavir, even to tenofovir. Addition of single active agents as new drugs were developed equaled or equated to serial monotherapy, generating multi-drug resistant virus. So for example, patients who were failing on the combination of zidovudine and lamivudine then added indinavir when the protease inhibitors became available, could not achieve full suppression and promptly developed indinavir resistance, accumulated more mutations to the protease inhibitors, and had now a multi-class resistance. Transmission of drug-resistant virus, including transmission of multi-drug resistant virus, exacerbated that problem. Fortunately, for most patients nowadays, we see that resistance is becoming less of an issue. These data that were published several years ago now look at the trends in resistance, and it's most informative to look at it by year of treatment initiation and to look at whether people had a history of single or dual use of nucleoside RT inhibitors, were ever had genotypic resistance after treatment initiation, or had 3-class resistance. And then in the triangles, these purple triangles or blue triangles here, what you see are all people on treatment. So before 1999, there were not huge numbers of people starting treatment. That's because we hadn't yet gone to starting everybody at diagnosis. But you can see that there were significant levels of resistance in people who had been on antiretroviral therapy, shown here in these red circles. Then in the period leading up to 2006, again, we had more people starting on treatment, but then leveling off a bit, but an increasing number of people who had genotypic resistance testing after starting treatment, meaning they had had an episode of virologic failure. And we see that there was some rate of drug resistance. However, in the people who started treatment in the most recent era, we see a big jump in the number of people on treatment, reflecting the changing guidelines for therapy, but many, many fewer people with failure or resistance. Similarly, if we look at the frequency of high-level antiretroviral drug resistance in the United States over a roughly similar period, and these are data from Ron Kagan published last year, we can see that although there is a relatively high prevalence of single-class resistance, this is mostly either resistance to 3TC and FTC or a resistance to efavirenz, there is a decreasing incidence of dual-class resistance and a very low rate of triple-class resistance, with an increasing number and proportion of patients who actually have no antiretroviral drug resistance, which is really very encouraging. Well, what about the patient who does develop drug resistance? How should we be managing them? According to the US Department of Health and Human Services antiretroviral treatment guidelines, the first step in dealing with virologic failure is to evaluate the patient's adherence, determine whether there are any potential adverse drug interactions, inquire about the tolerability of the regimen, and any history of prior drug resistance from previous treatment regimens. And then perform drug resistance testing. This is usually genotypic resistance testing, because the goal of treatment is to reestablish virologic suppression. A new regimen should include at least 2 and preferably 3 fully active agents, because as previously discussed, adding a single antiretroviral agent to a virologically failing regimen is really giving serial monotherapy and is strongly not recommended. Some highly treatment experienced patients, however, with extensive drug resistance may not be able to achieve maximal viral suppression because of the absence of a sufficient number of drugs, and that will be addressed in subsequent talks. In such cases, treatment regimens should be designed to minimize toxicity, preserve CD4 counts, and delay clinical progression. Well, how is it that we go about determining drug resistance? The most common approach is to use genotypic assays for drug resistance. These determine the presence or absence of specific changes in different viral genes that are targets of our drugs, such as the protease, reverse transcriptase integrase, or envelope proteins. But in order to interpret a genotypic resistance test, it presupposes the knowledge of critical mutations, and drug resistance is really being inferred by detecting the presence of these mutations. There are various methods and platforms for doing the genotyping, but all of them require an interpretive algorithm. Now, by contrast, phenotypic assays of drug resistance actually measure how much drug is needed to inhibit the virus in a tissue culture system. And you can ask how much is needed to reduce virus production by 50% or 90%, generating the inhibitory concentration, or IC50 or IC90. And these assays have become really very precise, and you can measure between 1.5 and 4-fold changes pretty reliably. The challenge, though, is that unlike for antibiotics and some antifungal agents, we don't really have clinically relevant breakpoints for most of our antiretroviral drugs. We know what the average susceptibility is for a wild-type strain, but we don't know how much of a shift in IC50 is needed before the drug is no longer effective in a patient. So it's important to remember that phenotypic assays measure drug susceptibility, but the definition of resistance requires clinical correlation, and we have that only for some of our drugs and for fewer of the newer agents. How is it that we actually get a resistance test done? Well, a sample of plasma is obtained, and from the plasma, viral RNA is extracted. It's converted to complementary DNA by a reverse transcription in the test tube, and then that cDNA can be amplified by PCR to generate amplicons either of the protease and RT region, or the integrase region, or the envelope. And then either these amplicons can be sequenced, or they can be used to construct either pseudotyped viruses or HIV recombinants that can then be put into a susceptibility assay to generate an inhibition curve. Also, if dealing with directly from cells looking at archived virus, instead of starting with plasma, you can extract the DNA from a cell, you skip the reverse transcriptase step and go right to PCR amplification, and again, then go on to sequencing if you're obtaining a genotype. Now, speaking for a moment about resistance testing based on proviral DNA, these tests may provide information about previously circulating resistant viral variants that are archived within the proviral DNA, but these assays also can miss some or all prior resistance mutations that have occurred in the quasi-species because they may be present at too low a level to detect, remembering that very few of the circulating lymphocytes actually harbor proviruses. It's also important to recall that most of the proviral DNA that is found in circulating cells actually makes up defective proviruses, with only a small fraction of the proviruses having intact sequences that could lead to infectious virus. So much of what we may be detecting in proviral DNA may in fact be irrelevant. So the clinical utility of these assays has not been fully determined. So in conclusion, assessing and managing patients who are experiencing antiretroviral treatment failure is complex, and expert advice should be sought. Performing drug resistance testing and considering all previously detected drug resistance mutations is important when selecting a new regimen in patients who are experiencing treatment failure. A new regimen should include at least 2 and preferably 3 fully active agents in order to be able to achieve control of viral replication. Newer agents, combined with other active drugs, may be options for heavily treatment experienced adults with multi-drug resistant infection and virologic failure. Thanks for your attention.